Welcome back, everybody, and very good morning. Now, today's topic of discussion is an extremely important topic, that is complications in a preterm newborn. Now, this is something which is extremely important for all obstetricians and gynecologists because preterm delivery is something we all want to prevent as obstetricians, and it's a challenge to the neonatologist. So, why is it that the preterm infant is so important? That is what we are going to look into in this session and discuss about the various complications which the preterm infant can suffer from. So, when we talk about prematurity is a certain state of immaturity in the newborn infant. Now, that immaturity can affect any system of the preterm infant. It could be the brain, it could be the lungs of the infant, it could be the eyes, the heart, or the colon. So, at various levels, there are a lot of complications which the newborn is prone to suffer from. So, why and how these complications take place and what is the treatment for it is our topic of discussion today. Now, we will talk about the first most commonly happening or the common problem in preterm neonates, which is the respiratory distress syndrome. Now, respiratory distress syndrome is a situation where the lungs they kind of become stiff. It's like a stiff balloon which doesn't open up enough to accommodate air inside, and because of which, due to the lack of air entry or air inflation into the lungs, there is hypoxia and respiratory distress. So now we are going to talk about the etiology behind the respiratory distress syndrome. Now, etiology means what is the cause of this distress and what is at what level does this immaturity in the lung takes place. Okay, so there is something we know as the alveoli, which is the terminal part of the respiratory tree where we have the air which is there in the lungs. When the lung opens up during inspiration, it is the alveoli which is opening up to accommodate the air. So if the alveoli they don't open up sufficiently during expiration, if they collapse, then definitely there's going to be hypoxia in the newborn child, and we do not want that. And that is the reason the creator has given us something called the surfactant. Now, what is the surfactant? Surfactant is a molecule which is present in present by the time an infant becomes term. Now, this is a lipoprotein which is produced by the type 2 pneumocytes of the alveolar cells. Now, what is a lipoprotein? First of all, lipoprotein is a molecule which is made up of proteins and lipids. And type 2 pneumocytes are the cells which are present in the alveoli. We have three kinds of cells present in the alveoli: type 1, type 2, pneumocytes, and we have the macrophages. So these are the three kinds of cells which are present in the alveolar pneumocytes, and of which type 2 is of utmost importance in this context because they are the cells which produce this beautiful molecule which is known as the surfactant. Surfactant is something which reduces the surface tension leading to an open alveoli. Had the surfactant not been there, the lungs would have collapsed during expiration, which is not happening for us. That means it is the surfactant which has kept the lungs open for all of us. Now, if we look into the surfactant molecular structure, it has a water-loving pole and a water not loving pole, that is a hydrophilic and hydrophobic end. The hydrophilic end is towards the alveolar fluid which is present at the rim of the alveoli, and the phobic or not water loving pole of the surfactant molecule is towards the air, that is the cavity of the alveoli. Now, so this structure, the water loving portion is pulled towards the outer side and the water hating portion is towards the air, maintaining the shape of the alveoli, the open shape of the alveoli during expiration. Now, suppose if this structure or this particular molecule is not produced, which is the case in preterm infants like 28 weeks, 30 weeks. At that time, this immaturity due to not production of the surfactant molecule leads to the collapse of the alveoli during expiration, causing hypoxia, and that is the etiology behind respiratory distress syndrome. I would want to take this opportunity to talk about a few proteins which are present in the surfactant molecule. So we have talked about lipids. It has a lipid tail and it also has some proteins which are of utmost importance. Now, why is it that the proteins are important? We know that this molecule is produced from the endoplasmic reticulum and then it is packaged into the lamellar bodies present in the type 2 pneumocytes. Now, from the lamellar bodies, it is produced into the cavity of the alveoli through exocytosis. Now, there are some proteins which help in the transport of these molecules from, that is the surfactant molecules from the lamellar body into the alveoli by exocytosis. This transport protein, one of the important transport proteins is ABC3. This is a question and an important point because if this ABC3, that is ATP binding cassette protein 3, if this protein is missing, then you can have an RDS kind of syndrome even in a term, because over there the problem is at the level of this transport. So it is not the production but the transport. The ATP binding cassette protein deficiency can also lead to situations just mimicking an RDS of a preterm. This situation can happen even when the baby is term. So a term neonate with RDS kind of a scenario, we can think in lines of ABC3 protein deficiency. There are other 4 proteins also that we can talk about, of which SPB and SPC, surfactant protein C and surfactant protein B, are important because again their deficiency can lead to RDS kind of a picture. SBC and B both, that is the surfactant protein B and C, these are water hating, that is they are hydrophobic proteins. SPC protein, it helps in the distribution of the surfactant evenly along the lining of the alveoli, and surfactant protein B, B is for packaging in the lamellar bodies. So either the packaging or distribution, anything, if it doesn't happen properly, then again you will have RDS kind of a picture. And there are other surfactant proteins, that is A and D, but they are not very significant in human studies. They are hydrophilic, water loving, but the more important proteins that can be worrisome are surfactant protein BC and ABC3. So these are the ones that we have to remember. And we have to know the mechanism of surfactant production and its function. So this is the reason that surfactant is the very important molecule when we have to know about respiratory distress syndrome. Now, the cause behind it, as we now know, is immature lung with surfactant deficiency. Definitely that will not lead to opening up of the lungs. The lungs will collapse, especially when the child tries to expire, during expiration, and that will lead to hypoxia. Now we know that after the child is born, especially after vaginal delivery, whatever fluid was there in the lungs, it is expelled out, and during delivery by compression or by lymphatics. But if the lung is not breathing enough, if there is persistence of the fetal circulation, then in that case, definitely due to this problem, this scenario, lungs not opening up, there'll be pulmonary artery hypertension leading to a right to left shunt, because we know that when the lungs have not opened up, the pulmonary artery which was going towards the lung, there is increase in pressure in its outflow that leads to a back pressure and a right to left shunt. So a right to left shunt and pulmonary artery hypertension will be associated in most cases of RDS. Now, since there will be hypoxia, it will lead to cerebral palsy or brain damage. Okay, so this is what can be associated with respiratory distress syndrome. Apart from its effect on the pulmonary artery, the right to left shunt, and cerebral palsy, it will lead to pneumocyte ischemia due to compromised nutrition of the pneumocytes, and that will lead to necrosis of the alveolar cells. So alveolar cells, again, they will start to undergo necrosis, and slowly they'll undergo sloughing. Okay, so due to hypoxia, there is necrosis of alveolar cells. There is, and definitely there's associated PAH, shunting, and cerebral palsy. Okay, now apart from a preterm surfactant deficiency, there are other scenarios where you can have a similar picture, like sepsis, pneumonia, because again, inflammation tends to inactivate the surfactant molecule. So sepsis, pneumonia, or meconium aspiration syndrome, again, that is an inflammation. Pneumothorax, persistent fetal circulation, it is a similar picture where you have a pulmonary artery, there's right to left shunt. So basically anything where the adult circulation is not being established, there's persistence of fetal circulation, that will lead to a picture like RDS. Then there is heart failure, similar picture, or any kind of situation where the lungs don't have enough space to expand. Like suppose if you have a congenital diaphragmatic hernia, it is not allowing the lungs to expand. The diaphragm is pushing into the thorax. Again, in those cases, lung is not able to expand. You will have a similar picture, just like the respiratory distress syndrome. And definitely the ABC3 protein deficiency, which is the transporter for the surfactant molecule from the lamellar body into the alveoli. Again, this transport protein deficiency can lead to a picture of respiratory distress syndrome, also in term neonates. Okay, so that is all about the etiology of respiratory distress syndrome. It's a very, very easy kind of a thing. The best way to understand it is thinking of a balloon that doesn't open up, doesn't open up, doesn't open up, and the treatment is how we will open it up. Okay, so now we come on to the clinical scenario. Now the baby is born. How do we know that the preterm has got this problem? So clinically, first we will assess. Now it generally sets in within the first 24 hours of delivery, and the severity increases in the first 2 days, that is 48 hours. So within a day or so, the child undergoes respiratory distress. There is nasal flaring and grunting because the child is trying hard to maintain some end expiratory pressure so that the lung doesn't collapse during expiration. So the child tries through the nose to maintain some pressure during expiration. So there is grunting and nasal flaring. The lungs do not open up well, so there is chest retraction, grunting, nasal flaring, chest retraction, and these are the Apart from these symptoms, there are some signs which will be evident, like decrease in oxygen saturation, increase in the carbon dioxide levels, that is respiratory acidosis. There is hypertension. Hypertension, the reason is not very well known why it happens. It could be because of so much hypoxia leading to myocardial dysfunction or peripheral vasodilatation, decreased vascular resistance for whatever reasons, but there is hypertension in the child, and definitely since the lungs are not opening up, there is pulmonary artery hypertension and right to left shunt. So this is the clinical picture with which the child would come to you. Now, the first investigation that comes to the doctor's mind is doing a chest x-ray. Now, the typical picture is a small lung. When you take the sky hardly inflated,